Compassionate Care, and we are in for a treat today. I have two young men with me, and they have very interesting careers to share with us. So today we have Gabriel, and we also have Harry, and they are respiratory therapists. Now, today, because we always hear about, physiotherapists, occupational therapists, I was very intrigued when I came and was seeing what they do. And so today, I would like to also share with you, the viewers today, what is the role of a respiratory therapist? Any
Well,
one of you guys jump in?
Go ahead, Gabe.
well, thank you for having us here today.
Yes.
Thank you for asking the question. It certainly is a very important part of the medical care. We provide support for not only the patients, but also their families and the team that surrounds them in their journey throughout the hospitals, right? Um, we work in many, many different areas of acute care, chronic care hospitals, community, research, teaching, etc. So we're going to start with acute care. When someone gets sick for whatever reason and they cannot breathe properly, we come into the picture, right?
Okay. Uh-huh.
Um, we are typically called to the emergency room stat, and it is not uncommon. It is very common that the RTs are the ones who actually intubate the patient.
So
That means
intubation means.
it means that we proceed
Mhm.
with the medical order, that we proceed to insert a
Okay.
tube through the patient's mouth
Okay.
into the patient's trachea, initially providing manual ventilation with oxygen, and subsequently connecting him to the mechanical ventilator.
Yeah.
And that's where the story starts. That's where the
Wow.
journey starts with the patient, right? Um, that patient is assessed typically by critical care physicians who transfer the patient to an acute care or critical care setting, ward, typically the ICU or coronary care unit. And from them, we place the patient on a ventilator. Our job is to initiate, support, maintain, and wean the patient from the mechanical ventilator. Keep in mind that that too can be in the mouth only for about 3-4 weeks. After that, the patient graduates or moves on to a tracheostomy, and that's what you have seen now.
Right.
Yeah.
So
Right.
that's what I came and
Right.
viewed how
Right.
to, intubate,
Now,
extubate.
during those 4 weeks, the patient may need an MRI or a CT scan or a bronchoscopy, and the RTs are involved.
Right.
Because we have to go with the equipment, we have to go with the patient, we have to provide support for
Yeah.
that patient that has to go through all those things.
Yeah, and like one of the things that we assume is that we're typically speaking with adult patients, is what we're assuming.
Correct.
But we actually work
Correct.
with all ages. So you will see RTs involved with the NICU. So right at birth, RTs are there. They help to maintain patency of the airway. They will help pediatricians and intensivists in a NICU setting to establish airways if needed. We also commonly think that when we're establishing airway, it's going through the mouth. But oftentimes, there are times where you'd have to even go through the nose, especially with children. And this is a very different skill that you're going to see in patients as well. And there's often times in specific roles, especially travel RTs or flight RTs, where there is no physician involved. There is an RT and an RN, and they are transporting patients overseas, and they're doing all of these emergency procedures that Gabe talked about as well. And these are all these emergent kind of cases where RTs are establishing ventilation and maintaining airways at that time.
The other part is that, as Harry was saying, we are involved with the care of neonates. So typically, the RTs are part of the team that takes care of difficult births,
Right.
either surgical births or natural births that are difficult. In that case, they probably have decelerations or meconium stain, so the RTs get called. Many times there's no physician. We end up leading the group. We intubate the baby. We initiate compressions, chest compressions for CPR if needed, and so
Right.
on. And again, we clear the airway if necessary. We put him on the ventilator, and we maintain, and we wean, and we extubate.
Right.
Right.
So for those individuals, when he said talking about meconium, meaning that there's the stool, the
Yes.
color of the stool, because they
Yes.
probably don't understand what that means, and that means
So-
that the
so the-
stool indicates
So the
that baby's-
pathophysiology of that is
Right.
that in utero, the babies are suffering from whatever,
Yes.
anoxia, lack of oxygen, or
Right.
whatever, right, inside the
They're
mother.
distressed.
So the sphincters of the anus relax, and he poops in the womb. And then we
amniotic
see
fluid.
that.
Yes.
So it's time to rescue that baby because likely he's going
He's in
to
distress.
choke and breathe it in.
Yeah.
Yes, yes. And so that's important also to know as well too for those individuals who might have had like a baby that was in distress. I know somebody here in the room has experienced that, and maybe later on we'll share about that in another interview. But that is something that most people, some people experience, and they don't understand exactly the mechanics of all of that. So when I came here, and I was just blown away by the techniques and the various things that you guys do as an RT. And I want to know, like, how many years have you been doing this, Gabriel?
33 now.
Wow, so quite experienced. Wow. And Harry did a phenomenal job with just breaking down information to me, just to make it simple. How to intubate and extubate and take off the patient off a vent. Now, Harry, you are your role is I know you're an RT, but you're
I'm the RT educator here at this center, but I work as a regular RT in other centers as well.
Right.
So
Yes.
so that's why we ended up working together, and I
educator.
kind of taught you how to take care of patients outside of hospital.
Right.
So one of the things that RTs do that we didn't mention is we kind of follow the patient not only in hospital, but then we travel with the patient. Their care extends to the community,
That's
right?
right.
Because not everybody can get off the ventilator. Not everybody's respiratory symptoms are resolved in hospital. Some people take a little bit longer. And for them, they get community RTs who are going to be doing a phenomenal job in the home. What we did together is just to educate you, because it's in some areas there is no RT services, so we need to upskill or uptrain a lot of other allied health, right? So that they have the knowledge that we do, so that you can take care of patients with these kind of potential issues, and that's what we worked on. So that's what I teach here. But there's RTs everywhere who do these kind of things. Gabe was also an educator.
Yeah. So I think overall it's extremely important to highlight of some details that happen when the patient's in the ICU. How do we know that we're doing the right thing with the respirator?
Good question. Yes.
We have to know.
Right.
So one of the skills that the RTs have developed throughout the years is that they actually insert the arterial lines.
Right.
Right?
Yes. Yes.
So it's a line that goes inside of the radial artery typically, sometimes inside the femoral artery.
Yes.
And it's like a little tap. So you can get blood work anytime you want without poking the patient. So that blood work goes to the lab, and then we see the results, and we know
What's happening?
what needs to be increased or decreased.
And based
right,
off of
into the
that,
settings.
you treat the patient based off of the blood work, right?
Yep.
Correct.
The other setting of RTs that you might not know is that a group of people, of RTs, work in the operating room only,
Wow.
Yes.
Okay.
right?
Yes, they
So
do.
they do exactly what we do in the ICU, but faster.
Yes.
They insert the R line, they intubate, they prepare the patient, they ventilate them, and after the operation, they extubate patient, and the patient goes.
And the patient goes home.
Oh no,
Wow.
to the
no,
recovery
to
room.
the recovery. I was going to say, hold on. That's
First.
wait. That's too fast.
they come back
That's
to
too
us.
fast. That's too fast. Yes, that's right. Okay. Wow. So that's a lot.
Yeah.
That's a lot. And thank you so much for that breakdown. So when I know we touched a bit of the community, what happens in the community, and we're saying that. So what kind of challenges that the families might face in the community, going home with a patient on an intubator, being intubated, and this is the first time, like myself who might be training, seeing it for the first time. What does that look like? What kind of challenges can they see, and is there any help if they do face any challenges? What do they do?
So typically speaking, like Gabe was illustrating earlier, when a patient is intubated, it's a temporary mechanism because if the tube is to go through the mouth or the nose, the patient has to be heavily sedated in order for that tube to be maintained in that airway.
Right.
Right? So if for whatever reason the airway needs to be maintained, but for an extended period of time, we will then graduate to a tracheostomy tube, which is what you're seeing here. And that's what you're going to be learning about.
Right.
That's what we learned about as well.
Right.
So when we're going into the community, this is kind of what you are seeing.
What you will see.
Right? Now, the patients can be on event or off event. And in terms of what the RTs do and what their help role is, it is education, but it's also maintenance. RTs in the community will often change and maintain this tube. They will maintain settings in the community. They will be assessing the patient and trying to see how they can wean the patient off if possible, help communicate with other healthcare teams. What's interesting is even in the community, if the patient's having saturation issues or oxygenation issues, the RT in rural areas can even initiate oxygen, right? Because there isn't a physician present at the time, right? So there is a lot of onus put on the RTs to have knowledge of all these things and to guide not only families, but the full healthcare team on this airway, because oftentimes they are the experts on this topic.
Wow. That's just very insightful. Thank you so much, because for those individuals that, might have families right now, maybe in hospital or in ICU or going through these things, that's something to now know that if they go home, this is what it looks like going home, and you have support. There's support out there in the community to facilitate for your families. You're not left alone, which is important to know that there is help out there when you do bring your patient home on event. I deal with patients that go through trauma. That's one of my biggest areas I really like to touch on today. And I know that as, individuals that go through trauma, one of the things that they experience is, and when I say trauma, I mean that have gone through rape or they've gone through severe car accident, emotional trauma, physical trauma, all sorts of traumas that are out there. What happens, the first thing, some patients hyperventilate. Some of them, they don't breathe, they hold their breath in, and their rhythm has become off-kiltered. So how do we teach individuals that have gone through trauma how to breathe again? Because I know a lot of times even for myself, I have to think about how do we breathe? How do we naturally breathe? How should we naturally breathe? It's like deep breath in through your nose, mouth. Like, what do we do? Because I know a lot of times when individuals experience trauma, the breathing is off. The breathing is off, whether they're holding their breath in, they're not breathing out the way they should, there's not this normal breathing taking place. How can we teach a person to breathe? Is it through so we have a model here, is it through the nose or through the mouth? You breathe out, inhale, exhale, how do we do it?
So I think what we're getting at is that the patient is in some type of stress.
Some type of stress, and
at
you
that
want
time.
to calm them down.
Yeah. So I don't think this is necessarily like a physiological thing that we're dealing with. It's a mental thing. And
right.
RTs deal with this quite often. This happens
Right.
in many settings because we deal with a lot of trauma, both physical and mental.
Exactly. Yep.
And I think what we do is to help to bring the patient at ease,
Yes.
which is less so like a physiological thing where we're intubating or doing any of that stuff. It's more so talking to them in a calm tone, allowing them to breathe in through their nose, out through their mouth, focus and concentrate on that, like have some mindfulness breathing and really slow themselves down so that they're not having like an anxiety attack.
Right. That's the main thing.
But
yeah.
I don't think it's necessarily like do this or do that. There's multiple techniques.
Reassurance.
Reassurance.
Right.
Is a big thing.
Reassurance.
Yes. Reassurance.
Yeah.
Yes. Wow.
I wanted to mention that our umbrella is really big.
Yes.
Yes.
Okay.
Yes.
We cover a lot.
Yes.
Okay. Adults,
Yes.
Yep.
pediatrics, neonates, elderly, community, operating room, trauma, drug overdoses,
Yes.
strokes, cardiac events, burns, car accidents. We're there. We have the pulse of the hospital.
Yes. And I
Right.
love that. I love that.
Yeah.
Yes.
Unfortunately, we are the unsung heroes.
It is true. It is true.
I love that.
Yeah,
Yes, sorry.
oftentimes the RT will come, we'll do what we got to do,
Yeah.
and then we're out, and no one has any idea who we are.
Now,
Exactly.
I love how
Yes,
you
yes.
responded to the question of emotional distress
Yes.
and the implications of it in breathing.
Yes.
And you ask how is that we normally breathe.
Yes.
So in two lines, we as humans breathe on negative pressure
Okay.
in, but we breathe out on relaxation.
Okay, so how do we do it? Is it through the nose and mouth? How are we doing it? That's what I'm saying.
Well,
right?
your airway has access to both.
Okay,
right?
so both. Okay,
Yeah, you
so
can
where
see
do we
that
go
the
here?
pharynx
So,
is open to both.
right?
yeah.
Okay. Mm-hmm. Okay.
But it is more common that people breathe through the nose
Nose, right?
and exhale through the mouth.
Okay. Okay. So we need to, yeah.
And speaking of that,
Yes.
we take it for granted, but
We do.
we all speak on
Yes.
exhalation,
Yes. Yes. Yes.
and almost no one recognizes that.
That's true. That's
Right?
true. That's true. Absolutely. Absolutely. Well, today, wow, thank you guys both for your insightful interview. And this conversation was quite deep. And we have learned a lot from our RTs today. And we have a lot of takeaway to just simulate, just go over again. So I just want to thank you both for coming on for this interview.
having us.
Thank you.
Just to finish,
Yes.
it's only a 3-year program,
Yeah.
There
and
you go.
and there's 7 schools in Ontario.
All right. So
Yeah,
check
there's
it
a lot
out.
of RTs, you know, we
We
you.
need them.
We need
There you go.
We need
There you
people.
go. So if you're thinking about going into that career, it is only 3 years. It's not that long. So think about it.
After the 3 years of learning in accredited Ontario school, you receive the title of a graduate respiratory therapist. You still have to challenge the national exam, and then when you pass that, you become a registered respiratory therapist with the province of Ontario under your registration with the College of Respiratory Therapists of Ontario, and then your credentials become a registered respiratory therapist, RRT.
So thank you so much again for watching Compassionate Care, and make it a great day. Thank you. See you next time.
Thanks, guys.
Thank you. Thank you both. Yes.